So in the meanwhile, I'll just introduce myself. I'm Dr. Kajal Hadgawkar from Department of Pathology at DMMC, Panadongri. And a very good afternoon to everyone.
Absolutely.
Yeah, so this is a part of a series where we are trying to just go through the very basics of investigations, be it pathological investigations, microbiological or biochemical. Okay. So my today's topic is about CBC and PS. In a very brief, we will go through the salient features of what to look for and how to interpret a report of CBC and PS. So once we start sharing the PPT, we can start our today's session.
Just a minute, madam. Our today's organizing secretary, Dr. Ankush, will start the proceedings.
Yeah, sure.
Ankush, just we can wait for 2 minutes. It's yet just 1 minute now, and after 1 minute, you can start the proceedings.
Yes.
Yes.
Hidden camera. Camera on. Online.
Hospital.
Me background.
I request every participants to mute their speakers except for our today's honorable guest speaker and the organizing committee team members. All others will put their speaker on mute. So, Ankush, you can start the proceedings now.
Yes, sir. Suprabhatam. Good morning to all. Myself, Dr. Ankush Dikondwar, Organizing Secretary for the event. We are starting this particular webinar series on pathology to enhance and update the knowledge of Ayurvedic Vikrutik and PGs as per time. Our today's guest speaker is respected Dr. Kajal Hadgawkar Madam and Dr. Subhash Vagesar as chairperson for this session, president of our organization. Before I call our guest speaker for the guest lecture, I would like to invite our spokesperson, Dr. N. Ambishia ma'am, to introduce our organization, RVPGA. Over to you, ma'am.
Thank you, sir. Thank you, Dr. Ankush, sir. Am I audible, sir?
Yes, ma'am. Loud and clear, ma'am.
Thank you, sir. Good afternoon and namaskar, respected Dr. Subhash Vagesar, Dr. Santosh Shavan, sir, and Maidaniki Organizing Committee members, faculty members, and beloved students. Before starting the session, I would like to say a few words about us, our organization, RVPGA, Rognidan Evam Vigyan PG Association for Pathology and Radiodiagnosis. Our organization, RVPGA, was formed in the year 2016 under the able and dynamic leadership of Dr. Subhash Vagesar, with the aim to give the legal status of pathologist and radiologist to the postgraduates of Rognidan. Our organization is duly registered under Societies Act of 1896 at Charity Commissioner Office, Nagpur. Postgraduate students, teachers of Rognidan Evam Vigyan can become our member. Ours is the only organization fighting for the lawful rights of Rognidan PGs. Even the NCSM had also directed State of Maharashtra to consider RVPG as a stakeholder in the constitution of pathology regulatory body of the state. RVPG is pursuing this matter with the state and central government. Not only this, RVPG is constantly pursuing implementation of NCS and standard structure in all the private Ayurvedic colleges across the nation. All the communications are uploaded on our website, www.rvpga.com. Our activities include a regular conduction of online webinars and offline seminars, both on national and international platforms, hands-on training program for PGs at our NABL accredited pathology laboratory at Pune, publication of research papers of Nidan students and faculties in our journal IJDR, International Journal of Diagnostics and Research, legal fight for the issues of Rognidan PGs and employees, our faculties. Thank you, sir.
Thank you, madam, for precisely introducing our organization. Now, I would like to invite Dr. Santosh Chavan, sir, to welcome our today's guest speaker. Over to you, sir. Dr. Santosh Chavan, sir, please welcome our guest.
Yeah, thank you, Ankush sir. I, Dr. Santosh Chavan, Secretary General of RVPGA, take an opportunity and it's a great honor and pleasure on behalf of the entire team of our RVPGA to welcome today's speaker, Dr. Kajal Hadgaonkar ma'am, who is a faculty from Datta Mege Medical College, Nagpur. Welcome, ma'am, on behalf of our entire team of RVPGA.
Thank you.
I also welcome Dr. Subhash Wage sir, who is a president and today's chairperson for today's series, today's webinar. Welcome, sir, on behalf of entire team RVPGA.
Thank you very much, sir. You need not welcome me.
Really, I am welcome Subhash Wage sir. Madam, our Subhash Wage sir is trying to fulfill the dream of our respected Honorable Prime Minister Narendra Bhai Modi ji to become a skilled India. So RVPJ is trying to enrich, to update, to upgrade the knowledge of our Ayurveda graduates and postgraduates. Thank you, and I welcome all the participants for their active involvement, active participation in today's seminar. So I welcome all of you. Thank you. Over
Thank
to
you, sir.
Ankush sir.
Thank you, sir. Now, before inviting guest speaker, I would like to give introduction of madam. Dr. Kajal Hadgaonkar madam did her MBBS from GMC Nagpur, MD Pathology from NKP Sadhu Institute of Medical Sciences and Lata Mangeshkar Hospital, Nagpur. Ma'am was second topper in her MD, did SRship at TMH Mumbai, worked at RST Regional Cancer Hospital, Nagpur, Dr. Lal Path Labs, Pune, and Lata Mangeshkar Hospital, Nagpur. Now with this, I once again welcome and request ma'am to deliver her lecture on the subject.
Thank you, Mr. Ankush. Now, if we can please share the PPT, we can start our lecture today.
You can share, madam, by choosing the share screen option.
Okay. I've done the share screen now. If you can guide me. I cannot see the PPT yet. So we can start the presentation. As I've already explained, today's topic is CBC and PBS. So next slide, please. Next slide, please.
Ma'am, you can change by yourself, ma'am.
I am trying, but I'm not able to do it. I think Dr. Subhash has the controls. And Arvi Nagpur. Only these two names I can see in the list of flight control.
Ankush, if you have opened it, you can move on. Who had opened it?
No, sir, ma'am share the screen, and I think with navigation key, the slide may be changed.
I'm trying to change the slide by slide control, but it's showing only two people who have control. Actually, two people, Dr. Subhash and RVPGA Nagpur.
I made you co-host, madam.
Yeah, please do that. So I can.
I made you already.
But I am not able to.
Just click on the screen. Click on the screen and then move.
Yes. Thank you. Okay. So now I'll start the lecture with a quote. The eyes doesn't see what the mind doesn't know. So basically, whenever we are looking at a report, if we take today's context, if we don't have the background knowledge in mind, we will not see the very intricate details that the report can provide us. So with that background in mind, we will go through today's session. So start with CBC. Now what we are commonly using these terms CBC, PS or PBS. So what do you mean by these terms? CBC means complete blood count, while PBS means peripheral blood smear, more commonly known as PS, peripheral smear. Now, when are these investigations ordered? So in fact, they are one of the most common investigations that are ordered, and the common indications for them are to evaluate the overall health and to screen for any health problems. Like if we go to any doctor, or for that matter, if we want to take our own yearly investigation, so this is one of the first investigation that is ordered. Then they are helpful in diagnosing a health problem, in monitoring already known health problem, and also in monitoring the treatment for a known health problem. So first we'll see what are the parameters that we study under CBC. So CBC is evaluated under the following headings. Basically, it is nothing but a complete blood count. So we are evaluating the health of the blood components, and the major blood components are the red blood cells, the RBCs, the white blood cells, the WBC, and the platelets. So what are the parameters of the RBC, WBC, and platelets that we will be evaluating under CBC? So the RBC parameters are hemoglobin, the total RBC count, the packed cell volume, which is commonly known as the hematocrit, the mean corpusculum volume, the MCH, MCHC, and RDW. So many of us have seen these in the reports, but do we really know what they stand for and what kind of information these parameters are giving? We'll see them in detail. The WBC parameters that we evaluate is the total leukocyte count and the differential leukocyte count, while platelet parameters are the total platelet count and the mean platelet volume. So the RBC parameters, we'll look into them first. So hemoglobin. As we all know, hemoglobin is a molecule present attached to the components of the RBC, and it is a molecule responsible for the oxygen transportation, right? And the values, normal values are different for different age groups. And this is something that we know. Hemoglobin is something that we know. So if hemoglobin is low, we commonly call it anemia. And if it is normal, then we say, okay, the patient is non-anemic. But what about if the hemoglobin count is very high? So we should also know the causes of which can increase the hemoglobin count, like a condition, a neoplastic condition known as polycythemia vera. Certain chronic lung and heart disease can also cause increase in the hemoglobin count. Certain liver and kidney cancer, which secrete the erythropoietin, which is a stimulating hormone for production of RBCs. So it can cause an increase in the hemoglobin count. Smoking can cause increase in the hemoglobin count. In fact, this is a very common cause of increase in the hemoglobin count. And chronically low levels of oxygen, as can be seen in people residing in high mountain areas where the oxygen content of the air in those areas is low. So these people will have higher hemoglobin count. And low causes, as we all know, low cause of hemoglobin is anemia, which can be seen in iron deficiency anemia, in megaloblastic anemia, in certain kind of cancers as well, and under certain medications like chemotherapy. Second parameter is the RBC count. That is, what is a total red blood cell count? It is counted in millions. So what are the causes of low RBC and high RBC? See, mind you, of course, RBC count and hemoglobins are correlated, okay? But it does not necessarily mean a decrease in the hemoglobin means a decrease in the RBC count and vice versa. Let's first go through the causes of low RBC count. So acute bleeding is a case in road traffic accident and large volume of blood is lost. So acute bleeding or chronic bleeding, say a patient is having a peptic ulcer disease and it is bleeding in a regular manner. So these can cause a decrease in the RBC count. Hemolytic anemias, which causes destruction of the RBCs like sickle cell anemia, thalassemia, they also cause decrease in RBC count. Certain nutritional deficient conditions like B12 deficiency, they cause decrease in the RBC count. But mind you, iron deficiency anemia, which is also a cause of nutritional deficiency anemia, will result in actually increase in RBC count. Okay. So certain bone marrow disorders or damage to the bone marrow where the production of RBC is affected. So obviously it will overall give a decrease in RBC count, and many chronic kidney diseases, because kidney is a source of erythropoietin, and erythropoietin is what stimulates the bone marrow to produce RBCs. So if there is decrease in erythropoietin because of a kidney disease, it will ultimately result in decrease in RBC production and hence decrease in the RBC count. So these were the conditions causing low RBC count. So what are the conditions causing high RBC count? Dehydration. See, RBC, as we all know, the component of the blood is the cellular and the plasma component. The plasma component is mainly made up of water. So if the patient is in a condition of dehydration, the plasma volume will decrease and relative increase in the cellular volume will be there, which results in increase in the RBC count. There are certain pulmonary diseases which lead to a state of hypoxia, chronic hypoxia. Now, hypoxia means decrease in oxygen content in the blood. So it stimulates the kidney to secrete more erythropoietin, which in turn stimulates the bone marrow to produce more RBC, and this overall results in increased RBC count. So any chronic pulmonary disease which results in the state of hypoxia. Now, kidney tumor or any other tumor in the body which is producing excess of erythropoietin will again result in increased RBC count. Smoking produces increase in RBC count by creating a condition of hypoxia in the body, because as you know, smoke, the main content of the smoke is carbon monoxide, which And carbon monoxide has more affinity towards the hemoglobin rather than the oxygen. So it gets attached to the hemoglobin molecule and the transportation of oxygen is hampered. So the blood in our body in a state is in a state of hypoxia, which stimulates the kidney to produce erythropoietin, and the whole cycle again continues and results in production of increased RBC count. Polycythemia vera is a neoplastic condition where there is some genetic abnormality in the stem cells of the RBC, and hence they undergo repeated cycles of proliferation and result in increase in the RBC count. Next parameter is the packed cell volume or the hematocrit. Now, packed cell volume is nothing but, as you can see in the diagram, it is nothing but the volume of the complete cellular components, okay? And the major cellular component in the blood is the RBC. The RBCs are in millions, the WBCs are in thousands, and the platelets are again in thousands. So the major component of the cellular component of the blood is the RBC. And that is what we are measuring here as packed cell volume. Another name for packed cell volume is hematocrit. So as you can see, it reflects the amount of RBC that is present inside the patient. Okay, so the causes of increase and decrease of packed cell volume would be similar to that as we have already seen in increase and decrease causes of RBC count and hemoglobin. Next parameter is mean corpuscular volume or MCV. So it is, what is MCV? As the name suggests, it is the volume of a single RBC. So we are estimating what might be the size of the volume of a single RBC, mean corpuscular volume. So it's actually an average of the total RBCs present. Okay, so it's mean of the total volume of all the RBCs. So it gives you an idea of the size of the RBC. Now, why it is important? As we all know, anemia has two kinds of classification. It is etiopathological classification, where we try to find out the cause of anemia, like nutritional, hemolytic, and all that. The other classification is depending on the morphology of the RBC. So depending on the size and the color of the RBC, it is divided into microcytic hypochromic anemia, macrocytic anemia, and normocytic normochromic anemia. So where are these, like how is this classification made? So the microcytosis, that is smaller size, macrocytosis, that is larger size, and normal cytosis, that is a normal size, which as we can see here is 77 to 95 femtoliter. So this, the volume, if it is between, if the volume of the RBC falls between 77 and 95, it is normocytic. If the value is less than 77, it is microcytic. If it is more than 95, it is macrocytosis. So why is it important? Because the etiology of certain anemia will cause the morphology of the RBCs to vary. For example, iron deficiency anemia presents with microcytic anemia, and B12 deficiency or folic acid anemia present with macrocytic anemia, whereas anemia of chronic diseases present with normocytic anemia. So here, this MCV value, a single parameter of MCV, can tell us what kind of anemia the patient is having. So the causes of low MCV, that is the size of the RBCs are less than 77 femtometer, is most common, especially in our setting, is iron deficiency anemia, thalassemia, congenital sideroblastic anemia, lead poisoning, pyridoxine deficiency, and anemia of chronic diseases. Mind you, the list is very long. These are the more common causes. Now, in the same way, causes of increase in the volume of the RBC. So it can be divided into two types: megaloblastic anemia and non-megaloblastic anemia. Now, megaloblastic means what? Megalo means large, and blast is some kind of precursor cell. So the precursor cell for RBCs, which cannot be seen in the peripheral blood but in the bone marrow, is known as normoblast. So if they are very large in size and have a very typical appearance, we say it is a megaloblast. And the megaloblast will produce big RBCs in the peripheral blood smear. So depending on the etiology of the large size of the RBC, we divide it into megaloblastic and non-megaloblastic. The most common cause of megaloblastic anemia in Indian setting is vitamin B12 and folic acid deficiency, which comes under the nutritional anemias. Atrophic gastritis, or gastrointestinal malabsorption problem, because intrinsic factor, an important component in the absorption of B12, is secreted by the gastric mucosa. And if there is some issue with the gastric mucosa, the secretion of intrinsic factor decreases and the absorption of B12 decreases. So it indirectly produces a B12 deficiency, leading to macrocytes on the CBC report, and the cause is megaloblastic macrocytosis. Now, other causes of macrocytosis, where the bone marrow will not show megaloblast, hence the name non-megaloblastic macrocytosis, is chronic alcohol abuse, hypothyroidism, chronic hemolytic anemia, chronic hepatic disease, and certain bone marrow disorders like myelodysplastic syndrome. Next, we are clubbing two parameters, MCH and MCHC. Now, MCH means mean corpuscular hemoglobin, that is the content of a single cell. As we can see here in the lower section, we are showing three RBCs. The center one is a normal RBC. See, now RBC is a 3D structure. We know the shape of the RBC is biconcave, like this. Okay. So the center part, the membrane are touching each other and they are devoid of hemoglobin, and the periphery is where the hemoglobin content is there, which gives in the 2D the appearance of a central pallor. Okay. The normal size of the central pallor should be 1/3 of the volume of the RBC. If you see on the left side, you can see there is just a rim of cytoplasm, that is hemoglobin, in the RBC. So it is a hypochromic because the color, the red color of the RBC is reduced. Hence we call it hypochromic, and it will indicate that the hemoglobin content is low, MCH is low. But on the right side, you can see the central pallor is completely absent. So it gives a hyperchromatic color to this, and it indicates a high MCH. So MCH measures the amount or the mass of hemoglobin present in one RBC, and MCHC, it indicates the percentage of volume taken up by the hemoglobin in that RBC. Okay, so they are decreased in microcytic anemias, normal in macrocytic anemia, and elevated in conditions where the biconcave structure of the RBC is lost and it becomes a sphere. So the central pallor is lost and it gives a dark chromia color. The condition is known as spherocytosis, or in certain conditions like sickle cell anemia. Now, the last parameter that is there is the red cell distribution width. It is nothing but it tells you the variation in the size of the RBC. Normally, as we have seen, the range of the RBC is 77 to 95 femtoliter. So it is a very narrow range. If the variation in the size of the RBC is, say, suppose 57 to 107, so you can imagine that patient must contain RBC of very small sizes and also very large size. Okay, so that will give you a variation in the size of the RBC. If you see the graph here, it is a bell-shaped graph, which is, and as we can see, the distribution is between 80 to 100. We take it for our convenience. Suppose the normal volume MCV is 80 to 100. So this is how the graph should look like. And the distance between the widest part is what is known as the red cell distribution width, RDW. If you see on the right side, there is variation in the size of the RBC. We can see very small RBCs and very large RBCs also, along with normal RBCs. So if you see the distance between the base of the two lines, we can see it is increased. So that is what we know as elevated RDW. That simply means that the size of the RBC is of various sizes there. And the causes, most common causes, iron deficiency anemia, dimorphic anemia. Dimorphic anemia means it contains two types of RBC, microcytic hypochromic RBC and macrocytic RBCs. That gives us a clue that patient is suffering from both iron deficiency anemia as well as B12 deficiency anemia. And that is termed as dimorphic anemia. The sickle cell anemia will have different sizes of RBCs. Chronic liver diseases and myelodysplastic syndrome will also cause an increase in the RDW. So these were the RBC parameters that we studied. So hopefully next time when you look at the RBC report of the CBC, we just don't stop at looking at only the hemoglobin. We should just go beyond the hemoglobin and look at the other parameters also, MCV, MCH, MCHC, RDW. Okay. So now next we move on to the WBC parameters. The WBC parameters are divided into total leukocyte count and differential leukocyte count. As we all know, leukocyte is a term used for white blood cells, that is WBC. Total leukocyte count is simply the total count present, the total leukocyte present inside the human body. And the differential leukocyte count is, as we know, white blood cells are divided into 5 types: the neutrophils, the lymphocytes, eosinophils, basophils, and monocytes. Excuse me. So when we give a differentiated count, that is what percentage of how many neutrophils are present, how many lymphocytes are present, etc. That is known as the differential leukocyte count. Excuse me, I'll just take a sip of water. Sorry for that. So we'll go for total leukocyte count. So the normal range of total leukocyte count in the body is around 4,500 to 11,000. See, these values are all the values that I am showing here. They vary from machine to machine, lab to lab. There's minor variation. Some lab will have a normal range of 4,500 and 11,000. Some lab will have, say, 4,000. Some lab will have 5,000. So the variation is minor, but these numbers are not absolute. Okay. So the normal range is 4,500 to 11,000 white blood cells per microliter of blood. So we have to now learn certain terms like leukopenia and leukocytosis. Now, as we know, leuko means white blood cells. Penia means decrease in number. Cytosis means increase in number. So leukopenia means there is a decrease in the total white blood cell count. And leukocytosis means there is increase in the total white blood cell count. You will also notice a term known as absolute leukocyte count. See, how do we calculate differential leukocyte count on the blood, on the blood film? We'll see what is absolute leukocyte count when we are dealing with peripheral blood smear. Okay, but just remember that absolute leukocyte count is nothing but the absolute number of neutrophils present. So if 4,500 is, suppose my patient has a TLC count of 6,000. So what is the percentage of neutrophil which occupy the out of the 6,000? It is 60%. So that is percentage, that is 60% of the blood, white blood cells of the total 6,000 is neutrophil. But if I ask you what is the actual number, what I will do, I will multiply 60,000 with 6,000, 60% with 6,000, and the value that I am getting is 3,600. So of the total 6,000 WBC in the circulation, 3,600 are neutrophils. And that term is known as absolute count, absolute leukocyte count. So it can be, you can ask a pathologist to tell you what is the absolute eosinophil count or absolute lymphocyte count. So this is how it is calculated. Now, what are the various causes of leukopenia? So why it is important for us to know the causes? If we don't know the causes, then we cannot ask the patient to undergo further investigations, right? So if I'm suspecting an infectious cause, I will, for example, here, the infection like viral infection, typhoid, malaria, TB, dengue, sepsis. So these can cause a decrease in the total blood cell, white blood cells. So the value of the patient with these conditions can be as low as 2,000. So total leukocyte count can be 2,000. So what if I, in the CBC report, I see a value of 2,000 for TLC, I will advise the patient further test, like I will advise the patient to undergo HIV testing or a Vidal test for typhoid or a HRP2 test for malaria, right? Tuberculosis kit, I can ask them to undergo further investigations. So for that reason, we should know a list of causes which can influence the condition. More common than infection is drugs. So there are many drugs which causes decrease in the leukocyte count. Clozapine, Brufen. Brufen is a very commonly used drug. So it also causes a decrease in the total white cell count. Valproic acid, minocycline. So there is a very big list of drugs that can cause these conditions. Also important to note that if a patient is coming with an already decreased TLC because of some other condition, we have to be very careful before giving these drugs, which are known to decrease the TLC. So the patient is already having a decreased TLC, and if we give the patient these drugs, it will cause a further decrease in TLC, which can be very harmful to the patient. So decrease in total leukocyte count is also associated with chemotherapy, radiotherapy. Now, as we had seen in the beginning, the first slide was about the indications, like when is CBC ordered. So a patient who is undergoing chemotherapy and radiotherapy, then when should the patient receive the next dose? So after the first dose, say after a week or a couple of weeks, the patient is first advised to undergo CBC report. And in the CBC report, we expect that the patient had undergone radio or chemotherapy, so the counts will be low. But the bone marrow is given time to regenerate and increase the count. So in the next CBC report, if my counts are not increased, I will wait for one more week before giving the next dose of chemoradiotherapy. And in the next dose, if the counts are within acceptable range, then the patient gets the next dose. So this is what is called as monitoring the therapy of the patient, and CBC is used for monitoring the therapy of such patients. Then myelofibrosis and aplastic anemia. Now myelofibrosis is nothing but replacement of the bone marrow by fibrous tissue or fat tissue. And as we all know, bone marrow is the site of production of all the blood cells, whether it is red blood cell, white blood cell, or platelets. So in condition of myelofibrosis or aplastic anemia, there will be decrease in the total leukocyte count. And other causes can include certain condition, chronic condition like SLE, that is systemic lupus erythematosus, Hodgkin's lymphoma, and other kind of cancers. Causes of leukocytosis, that is increase in TLC, infection is the most common cause, bacterial or viral or any other kind of infection. Inflammation, any chronic inflammatory condition in the body, as like SLE or rheumatoid arthritis or any other kind of chronic condition which is causing inflammation in the body. There are certain malignant conditions, especially blood cancers, okay, leukemias, myeloproliferative disorder. This will cause an increase in the TLC. Allergies, asthma causes an increase in the TLC. Tissue deaths, like major accident has occurred, a lot of tissue damage is there, or a sudden major heart attack is there. Burn, the patient has undergone major burn. So these causes large amount of tissue destruction, inflammation, which results in increase in the TLC count. Now, differential leukocyte count, as we have already discussed, it measures the different types of RBCs. So as we can see here, there are two columns, percentage and absolute count. So percentage tells us what is the total out of the 100 WBC that I have seen, 40% is polymorphs or neutrophils, 20% is lymphocyte, 2% is monocyte, 1% is eosinophil, and basophil is less than 1%. So this is what is known as percentage DLC. An absolute count, as I have already discussed, it gives you a total number of those cells present. And whenever we are interpreting the report of a CBC, please pay attention to the absolute count rather than the percentage. Why it is important to look at the absolute count? See, percentage, the denominator has to be 100. Okay, so how do we come to the percentage count? So what it is done, it is basically done that out of the 100 WBC counted, how many are neutrophils? Okay, so the denominator is 100 always. Okay, so if the patient is having some condition which is causing a decrease in the polymorphs. So more number of polymorphs will occupy, and the rest of the denominator will, the rest of the numbers will come down, because the total always have to be 100. But that doesn't mean, so if my patient is having 95% neutrophils, so lymphocyte will be 2%. That does not mean the total value of lymphocytes in the patient body is decreased. What the percentage is indicating is neutrophils predominant. So if I want to see whether the patient is having a normal lymphocyte count, I will have to go and look into the absolute counts. Okay. And if I see the absolute, what is the normal range of absolute counts for the lymphocytes? It is 1,500 to 4,000. So if, in spite of the fact that the percentage is showing 2%, the count here is showing 4,000. So the patient is having normal lymphocyte count. Okay. But in spite of the fact that the patient is showing 50% and the total count is say 1,000, so the patient is having decreased lymphocyte count. Hence, we have to remember that whenever we are interpreting the result, the more important part is the absolute counts rather than the percentage. And all the reports that you receive will always have a normal range list there. So we have to compare the parameters of the patient with the normal range, so we get an idea whether the patient's values are normal, decreased, or increased. So we'll go very fast. The different conditions which causes an increase in the neutrophil count and decrease. So increase in the neutrophil count is known as neutrophilia, and decrease is known as neutropenia. As I've already discussed, these terms, see, as you can see here, it is not the percentage that is written here. It is the total number, that is the absolute values which is written here. So these terms are defined by the absolute values. So if the absolute values of neutrophil in the patient's blood is more than 7,000, it is termed as neutrophilia. And if it is less than 2,000, it is termed as neutropenia. So the causes of neutrophilia is physiological. A patient has just gone to gym and came to us, and we take a blood sample. The patient is bound to have neutrophilia. Okay. So what we will do, we will ask the patient to rest for a day, suppose, and we will repeat the count. If the count now should come back to the normal range. So that means the increase in the neutrophil count was because of the gym activity. But in spite of 1 day rest, the counts are still increased or were more than what it was in the previous day. That means some other pathological causes there. So the pathological cause most common is pyrenic infection, that is bacterial infection is the most common cause of increase in the neutrophil count. Then tissue damage like burns, myocardial infarction, myeloproliferative disorder, that is neoplastic disorders like polycythemia vera or CML, certain inflammatory disorders like rheumatoid arthritis, certain drugs, and acute hemolysis of blood. You will see a repetitions of the causes of TLC and neutropenia. See, what do you understand by TLC? Increase in the total leukocyte count. That increase will be because of increase in one or all of the component of DLC, right? So there will be overlap of causes here, but then we have to know that certain specific white blood cells are increased in certain specific diseases. So we'll see them further, okay? Causes of neutropenia is certain bacterial infections. See, most of the bacterial infection cause an increase in the neutrophil count, but certain bacterial infection like brucellosis, typhoid ulcers, and most of the viral infection cause a decrease in the neutrophil count. Bone marrow depression because of myelofibrosis or aplastic anemia will cause a decrease. Hypersplenism, that means the spleen is enlarged and it is destroying the blood cells, the red blood cells, the white blood cells. It is destroying because of some pathology. That causes a decrease in the, not only in the neutrophils, also in the total RBC count. Certain immunological condition like SLE, many drugs which cause a decrease in the neutrophil counts, and certain familial conditions. Now, it is very important to note that the patient is in neutropenia. See, you will see further the different causes of lymphopenia, basopenia and all those things. But the most significant of all the DLC is the neutrophil, which is decreased, because a decrease in the neutrophil count makes the person susceptible to those infections which otherwise the patient would have survived. So a decrease in the neutrophil count is a high risk for the patient. So if for some reason my neutrophil count is decreased, suppose I have had bone marrow depression and my neutrophil count is decreased, so I am susceptible to many infections and I have to take special precautions for that. The best example if I have to give for this is patients who have undergone chemotherapy, radiotherapy. You must have seen them wearing masks. Why they are wearing masks? Always washing their hands, using sanitizer, staying away from crowded areas, because of the chemo and radiotherapy, their total blood count, the RBCs, the WBCs, especially the neutrophils, are decreased, and this makes them susceptible to viral or bacterial infection. So they have to protect themselves. So if in your report you see a case of neutropenia, you should be on high alert. You have to find out the cause of neutropenia. In the meanwhile, you have the patient to take special precautions. Next, we'll see lymphocytes. So lymphocytes are basically certain cells. The main function of lymphocyte is protection against viral infections. So increase in the total number of lymphocytes is known as lymphocytosis, and decrease is known as lymphocytopenia. So the causes of lymphocytosis is, again, we have to look at the absolute value and not the percent. I will be repeating the same thing again and again, so that we, at the end of the lecture, we will, when we see the report, our eyes will automatically go towards the absolute count rather than the differential count. So what are the causes of lymphocytosis? As in neutrophilia, the first cause was bacterial infection. Here the first cause is viral infection. So viral infection, for example, mononucleosis, it causes increase in the lymphocyte counts. Then certain drugs, certain stress increases. As you have seen, in stress, neutrophil count increases, so does lymphocyte count. Many autoimmune disorders like rheumatoid arthritis, thymoma, the lymphocyte count is increased. And in leukemia, especially the acute lymphoid and the chronic lymphoid leukemia, as the name suggests, it's a lymphoid cells which are more in number. So you will see lymphocytosis in such cases. Now, what are the causes of lymphocytopenia? In general, malnutrition, the protein energy malnutrition, marasmus, kwashiorkor, the patient will have lymphocytopenia. Autoimmune disorders, myasthenia gravis, which is a condition of autoimmunity. Here also there is lymphocytopenia. Then use of UV radiation, chemo radiation, because it is causing a generalized bone marrow suppression. So all cell lines will decrease. Then glucocorticoid or steroid use, it also causes decrease in lymphocyte counts. Next blood parameter is the monocyte. Okay, so monocyte is the total percentage, it should be more than 100. If it is more than 100, it is known as monocytosis. If it is less than 10, it is known as monocytopenia. Okay, so causes is monocytosis in chronic bacterial infections. Most common chronic bacterial infection in our setting is tuberculosis. Typhoid also gives that, bacterial endocarditis. So here, these are the chronic infection that causes increase in monocytes. Connective tissue disorders, then protozoan infection, amoebiasis and like that. Chronic neutropenia can also induce monocytosis, lymphoma and CML. Monocytopenia, acute infection can cause a decrease in monocyte count, stress, aplastic anemia, leukemias, and treatment with chemotherapy and radiotherapy patients. Eosinophilia, see the next two components, eosinophils and basophils. The decrease in the counts is clinically not significant, so we will not deal with that. But the increase in count is important. So eosinophilia, that is increased in the absolute count of more than 600, is known as eosinophilia. And the four most common causes is allergy, parasitic infection, neoplastic conditions, and connective tissue disorder. Allergy like asthma, eczema, drug hypersensitivity, food allergy can cause an increase in the eosinophil count. Parasitic infections like hookworm infection or echinococcus, hydatid cyst infection, any kind of parasitic infection can lead to increase in the eosinophil counts. Certain neoplastic conditions like lymphoma, myeloproliferative disorders, can eosinophilic leukemia again causes increase in the eosinophil count, and certain connective tissue disorders like Chuck-Stewart syndrome, idiopathic eosinophilic pneumonia can cause increase in eosinophils in the CBC. So why are these? As if we see here, some diseases are common as we have seen in earlier conditions, but certain diseases are specific, like allergic reactions and parasitic infection. Okay, we did not see these two as causes of neutrophilia or lymphocytosis or monocytosis. Why? Because eosinophil is a specialized cell which is increased or manufactured in increased quantity to deal with these specific infections or infestation, because they contain the chemicals required to neutralize these threats of parasitic diseases or allergens and neoplastic conditions. In the same way, basophil, it is if the patient is having basophilia, that is increase in the basophil count, the first thing that should come in our mind is myeloproliferative disorder. Most common is chronic myeloid leukemia or CML. So this is one of the most common cause of basophilia. Other causes can be inflammatory condition like ulcerative colitis, Crohn's disease, a patient of chronic asthma. Hyperthyroidism can cause basophilia. A chronic diabetic can have basophilia. Certain infection like helminthic infection, that is parasitic infection, chickenpox, influenza can cause basophilia. So, but the increase in the basophil count in the rest of the condition will be minor. In a myeloproliferative condition, in CML, the basophil count is increased to even 1,000. So it is a very significant increase in basophil count. And if we see a very significant increase in basophil count on the CBC, we should evaluate the patient for myeloproliferative disorders. The last parameter that we study under CBC is the platelet, and it is studied under two headings: the total platelet count and the mean platelet volume. So the total platelet count should be in the normal range of 1,50,000 to 4 lakhs per microliter. And the increase in the total platelet count of more than 4 lakh is known as thrombocytosis, and the decrease will be known as thrombocytopenia. So let us see the causes of thrombocytosis. Here we have to remember two new terms, reactive and spurious. Spurious means by mistake. So it's an artifact. So because of, say, improper mixing of the anticoagulant with the blood, there might be a small clot which is formed, and the machine which is reading the platelet, it reads the clot and excess of platelet is reported. Okay, so that is what is known as spurious. So what we do in case of spurious, we take a repeat sample, a fresh sample, a repeat sample is taken, and it is rerun, and we see a normal range. So that is how we say, oh, so the initial report was spurious or an artifact. Next condition is reactive. Reactive means the problem is not with the platelet or the megakaryocyte. Megakaryocyte is the cell in the bone marrow from which platelet is developed. So the main problem is not with the megakaryocyte or the platelet. The problem is something else, and the megakaryocyte or the platelet is reacting to it, and hence an increase in the number. So in certain infections, inflammatory conditions, tissue damage, non-malignant hematological conditions, and post-splenotomy, what happens is the bone marrow in general undergoes a stimulation. So it is producing excess number of all kinds of cells, the RBCs, the WBCs, the platelet. So in this condition, there will be thrombocytosis, and it is known as reactive. And autonomous means now it is the megakaryocyte which is where the pathology rises. The rest of the parameters, the WBC, the RBC is probably normal. There is no increase in number. There is no difference in morphology, but it is only the platelets that is affected. So conditions like essential thrombocytosis, polycythemia vera, CML, primary myelofibrosis, we can see thrombocytosis. low platelet count, which is more dangerous than the high platelet count. So low platelet count means what is decrease in the total platelet less than 1,50,000. Now, why is it dangerous? It is dangerous because platelet is an important component which initiates the clotting of the blood. So as we know, the clotting of the blood is divided into two stages, the primary and the secondary. The primary is where the platelet plays an important role, and the secondary is where the clotting factors play an important role. So platelet forms a temporary clot, and that temporary clot is made permanent by the effect of clotting factors. So if the platelet count is low, the temporary clot formation is not there or it is not stabilized. And what will be the result? The patient will continue to bleed. So when there is low platelet count, that bleeding tendency of the patient is more. So it is the decrease in the platelet count is much more important rather than the increase in platelet count. And what are the conditions? Decreased production, increased sequestration, and increased destruction. So the production of platelet in the bone marrow is decreased. It can be due to decreased number of megakaryocyte production, or the megakaryocytes are adequate in number, but they are not producing effectively platelets. The causes of decreased megakaryocyte is aplastic anemia. Aplastic anemia means the bone marrow is not producing all the blood cells. So you will see aplastic anemia in all causes of decrease in RBC, in WBC, in platelets. Then toxic damage like chemotherapy, radiotherapy, and if the bone marrow is replaced by other cells like tumor cells, if there is metastatic deposits or large amount of metastatic deposit of tumors in the bone marrow, like prostate deposit or breast cancer metastatic deposit is there, or leukemic cells are replacing the normal erythropoietic cells. In this case, there will be decrease in production of megakaryocyte, hence decrease in total number of platelets. In effective megakaryopoiesis, that means that the total number of megakaryocytes are normal, but they're not producing the adequate amount of platelets. The causes are B12 and folic acid deficiency, or certain drugs which are not allowing the use of folic acid in the production of platelet, like methotrexate, which is a very common drug used for many types of chemotherapy, and other drugs. Second is sequestration. Sequestration, by the word sequestration, we mean that the platelet are being accumulated and trapped in certain organ. And the most common organ to do that is the spleen. So because of hypersplenism and splenomegaly, large amount of platelets are trapped inside the spleen. So the total number of platelets in the peripheral circulation decreases, and it causes decrease in the total platelet count. And the third cause is increased destruction of the normally produced platelet. So the bone marrow is doing its job. The spleen is not trapping the platelet, but still the platelet count is low. So what is the cause here? Increased destruction. So it can be due to antibodies against the platelets, which is immune and non-immune with certain other conditions. So SLE, chronic lymphoid leukemia, then acute promyeloblast or prolymphocytic leukemia. So these are the conditions where ITP, where autoimmunity plays an important role in thrombocytopenia. Alloimmune means anti-HLA antibodies. This is seen in patients of transplant, like kidney transplant, heart transplant, who over a period of time develops immunity against their own platelet and causes destruction of their own platelet, causing thrombocytopenia. And many drugs destroy the platelet by immune mechanism. And non-immune mechanism is by certain HELP syndrome as seen in pregnancy-induced hypertension. That is PIH patient. If uncontrolled PIH is there, patient can land into HELP, where one of the parameters of HELP syndrome is decrease in the low platelet count. The last LP means low platelet count. So yeah, that causes decrease in the platelet count. Then HUS, hemolytic uremic syndrome, DIC, that is disseminated intravascular coagulation, any kind of vascularity, certain infection can also cause decrease in the total platelet count. The more common cause, as we all know, in our setting, especially during the rainy season, is dengue. Okay, so in dengue patient, we all know that there is decrease in the lymphocyte count, but more significant and more dangerous is a decrease in the platelet count. And The main therapy in the initial stage is monitoring the platelet levels of the patient. We see whether they are decreasing or increasing. And a decision is made whether the patient requires platelet therapy or not, depending on that. So when we are evaluating, again, this is called monitoring the disease here. Monitoring the disease, whether the patient requires additional therapy or not. And one more parameter that helps in monitoring, especially in case of dengue, is the mean platelet volume. So as in mean corpuscular volume, which measures the mean size of the RBC, mean platelet volume measures the mean size of the platelet. The platelets are very small structures. We have seen that the RBCs are in the range of 77 to 95. The platelets are in the range of 9.7 to 12.8. Okay, so they are very small structures. But if the volume of the platelet is increased, that is, they are more than 12.8, what does that indicate? Why is it significant? See, small volume means small platelets and large volume means large platelets. And usually the premature platelets are larger in size. Now, why will there be premature platelets? The bone marrow is producing more platelets, and since there is decrease in the platelet in the peripheral circulation, it is ejecting the newly formed platelet out into the bone marrow even before they are mature. Normally, when the platelets are formed, they stay in the bone marrow for a couple of days and then they are released into the peripheral circulation so that they mature. But because since there is acute deficiency of platelet in the peripheral circulation, the bone marrow is now ejecting out the premature platelets into the peripheral circulation. And hence, in such cases, the mean platelet volume will be more. So how is it important to us? So if when I am evaluating a patient of, say, dengue, I look at two parameters: total platelet count, whether it is in an increasing or decreasing trend. What do we understand by that? We will usually such patient undergo a 4-hourly or 6-hourly CBC evaluation. And we make plot a graph of the platelet count. What was a graph? And we check whether it is having an upward trend or a downward trend. So in a patient with downward trend, we have to decide when to give the patient platelet therapy. In such case, we also look at the mean platelet volume. So if my mean platelet volume is normal or in the lower side, that means the bone marrow is not producing any extra platelet. Okay, it is not pushing out immature platelet in the peripheral blood. That means the bone marrow is yet to recover from the viral infection. So if the values of total platelet are decreasing to a significant amount, I will probably go and decide to give the patient platelet therapy. But in another scenario, when the values of total platelet are decreasing, but I see the mean platelet volume is actually increasing, that means the bone marrow is recovering from the viral infection. It is producing more platelet, and I can wait for a longer time to see whether the values of the total platelet will increase. And yes, in the next cycle, in the next 6 hours, I see, yes, the volume is now, the total platelet count is now increasing. So what has happened? I did not need to give a platelet therapy to this patient. The patient on itself recovered. So there is where the importance of mean platelet volume lies. So this was all about CBC, that is complete blood count. Now we will see what is peripheral blood smear. Peripheral blood smear is, again, we are evaluating the same things: RBC, WBC, platelet. A new parameter here is parasites. But now we are, what is the difference between CBC and peripheral blood smear is that we are actually directly observing the size, shape, texture, color of these cells under microscope. So that is the difference here. And the parameters, hence the parameters that we observe would be a bit different than what we had evaluated in the CBC. So RBC, we are measuring in terms of the size, the shape, the color, and if there are any abnormal RBCs present. So can anyone tell me in the chat box, what will the size of the RBC or peripheral blood correlate with which parameter of the CBC? Can anyone please tell me in the chat box, what parameter of the CBC correlates with the size of RBC in the peripheral smear. Yes. No, I'm not asking what is a comparison. Like, how do I compare the size of the RBC, whether it is normal or not? Yes, I'm getting some answers. So it is the MCV, which correlates with the size of the RBC on PS. And yes, it is also the RDW, which will tell us if there is a very large variation in the size of the RBC or not. So these two are the parameters. I'm very thankful for all the people who have answered, and they've answered correctly. So these are the two parameters which are helping us to cross, reference. So that is what you can do when you receive the report of CBC and PS. You can also cross check whether the report of the PS is correlating with the report of the CBC. Shape is something that we don't get in the CBC. So this is a new information that we are getting on PS. Again, color is MCH and MCHC, which gives us an indication of the color of the RBC. And here we just say whether it is hypochromic or hyper. And again, abnormalities of RBCs is something that we detect on peripheral blood smear. CBC is not of much help in telling us about abnormal RBCs. Now, WBC, both parameters, TLC and DLC, we are getting from CBC. So it is not of much advantage to do a peripheral blood smear, but if there are any kind of abnormal cells, then we do check it. And always remember, peripheral blood smear is a counter check of CBC. They are check of each other. So if both the values are not correlating, you can always call your pathologist and ask, why are the values not correlating? Where the problem lies. So a repeat test of the patient can be done and we can get a more authentic report. Platelet counts, again, the total count, we give an estimate of total count and any abnormalities are there. And the most important parameter, that is a hemoparasites, which we cannot evaluate on CBC. Although the newer machines are giving indirect evidence of presence of hemoparasites, but to type them, what kind of parasite is there, we have to do a peripheral blood smear. So erythrocytes, as someone has rightly pointed out, we are looking at the size of the erythrocyte. Now there is no scale to measure. So how will I measure if the erythrocyte that I see is normocytic, or smaller erythrocyte that is microcytic, or larger insides that is macrocytic? So I have an internal scale inside the smear. What is that internal scale? It is the nucleus of a small lymphocyte. So I will compare the size of the RBC with the nucleus of the small lymphocyte. If it is same, I will say it is normocytic. If it is smaller, it's microcytic. If it is larger, it's macrocytic. Okay. How will I identify RBC on the peripheral blood? It is an unnucleated cell. Okay. Can we see nucleated RBCs in the peripheral blood? Yes, we can see nucleated RBCs. See, the RBCs in the bone marrow are nucleated. The precursors of the RBCs in the bone marrow, which we call as normoblasts, they are nucleated cell, and they undergoes a series of maturation where in the last stage the nucleus is expelled out of the cell, and that condition is known as, the cell now is known as reticulocyte. It stays in the bone marrow for a couple of days to mature into a mature RBC, which is then sent out to the peripheral blood. So what are the conditions where we can see nucleated RBCs in the peripheral blood? When I think can please someone, please mute audience, please mute yourself. Yeah. So nucleated RBCs are seen where the peripheral, there is decrease in the total number of RBC in the peripheral blood, and the bone marrow is producing more number of RBCs, and it does not have time to let the RBCs mature, so it expels the reticulocytes or even the nucleated RBCs in the peripheral blood. Same condition that we have seen in case of platelets during dengue. So those are the conditions where we can see nucleated RBCs in peripheral blood. Normally, we should not see. So even if in your report is mentioned presence of nucleated RBC, So we have to evaluate why the patient is having nucleated RBC in the peripheral blood. We have to see the causes and evaluate accordingly. So let's see. So this is in the center, we can see a small lymphocyte and all the unnucleated cells here are the RBCs. We can see the central area, which is pale, which is known as central pallor. It should occupy 1/3 of the volume. And if you can see the nucleus of the small lymphocyte, it is same as that of the size of the RBC. So the RBC here is normocytic, and looking at the hypochromia, it is 1/3. So the RBC here is normochromic. Okay. So what are the conditions in the variation in the size and shape of RBC? And isocytosis. See, these are two very commonly used terms in peripheral smear. Peripheral smear, as we have already discussed, is in 4 headings: RBC, WBC, platelet, and parasite. So many times the report starts, there is anisocytosis and poikilocytosis. When I am using these terms, what do I mean? Anisocytosis means there is variation in the size of the RBCs. And how will I correlate this with the CBC? The RDW in this case would be raised. Okay. So anisocytosis means only variation in the size, and poikilocytosis means variation in the shape. So the shape of the RBCs should normally be circular. So it can be elliptical, spherical, target cells, schistiocytes, acanthocytes, echinocytes. We will not go into much detail. There is a long list of conditions for each conditions, but this is what I mean when I say RDW is increased or there is anisocytosis. So the PS will have this range of RBCs: microcytes, macrocytes, ovalocytes, hypochromic macrocytes. So this range of RBCs will be present. If I'm saying hypochromia, I mean again these range. So this is the normal chromia. As you can see here, only a peripheral rim is there, which is containing the hemoglobin. So this is severely hypochromic, mildly hypochromic, severely hypochromic. And polychromasia, that is, there is variation in the color. Normally it should be eosinophilic, but I can see a bluish tinge here. So there is variation in color. And what is this bluish tinge? It is speaking of nucleic acid. Reticulocytes contain some nucleic acid, and reticulocyte is nothing but the premature form of RBC. So if I see polychromasia, that means certain premature forms of RBC are there in the pelvis. And these are the various shapes of the RBC: the sickle cell RBC, the target cell RBCs. These are very commonly used. Spirocytes, again, as I mentioned, it is not biconcave, it is now become a sphere. Spirocytes, okay. Inclusions in the RBC. What do you mean by inclusions? There are certain particulate materials in the RBCs we can see. So again, different inclusions have different causes. And most importantly, agglutination and Role formation. Now, Role formation means what? It simply means the RBCs are stacked upon each other as points. We stack coins, like 5 rupee coins, one top of each other. That is Role formation. And agglutination means there is some kind of antigen-antibody reaction occurring and they are haphazardly combining with each other. So Role formation can be a finding on PS, which is not very important. But agglutination, if seen on peripheral blood smear, is very important because now we have to check the patient for autoantibodies. Chromia, as we have already discussed, hypochromia means there is decrease in the hemoglobin content. Hyperchromia means, can there be increase in the hemoglobin content? Actually, no. Hyperchromia does not mean an increase in the hemoglobin content. It actually means what? The volume of the RBC is decreased. Okay, it has become spirocyte. As we know, sphere is a condition where the volume is the minimum and it gives an appearance of hyperchromasia on the 2D image. So in spirocytosis, it is seen. Anisochromia or anisochromia means that presence of hypo and hyper or hypo and normal. It indicates multiple etiology. Okay, so a patient with iron deficiency and folic acid anemia will present with anisochromia, that is variation in the color. And polychromia, as we have already discussed, it means some premature forms of RBCs are there, most commonly seen in conditions of hemolysis or acute blood loss. So this is the actual photograph of microcytic hypochromic RBC. See, this is the nucleus of a, whenever we are going, looking at a, we want to compare the size and shape, first we have to look out a small lymphocyte. Once we have found a small lymphocyte, then we compare the size here. You can see they're all small. So this is microcytic. We can see the variation in the shape as well. Teardrop, elliptical. Okay, so these are the variation in the same shape. So when I'm describing this PS, I will write anisocytosis, poikilocytosis. In this condition, I will write only anisocytosis because there is not much variation in the shape of the RBCs. This slide is there to show you polychromatic. See, these are the RBCs here. This is what a normal RBC should look like. As you can see here, the central pallor is absent in this RBC and it is darker stain. So this is hyperchromasia. What kind of RBC is this? This is the spirocytes. Okay. Now this, you can see it is purplish, bluish tinges there. So this is polychromasia. It is having multiple colors. And this is a reticulocyte. And these are variation in the shape. So these are actually broken RBCs. Technical term for that is schistiocytes. So this whole is a case of hemolytic anemia. So in short about leukocytes, we have already discussed the causes of increase and decrease. We'll just see how they look like. Okay, I'll tell you the actual images. So this is a lymphocyte. We can again compare here. The size of the nucleus is that similar to that of RBCs. It is a small cell. The next cell is a monocyte. Here, the size, it is one of the largest cell of the normal peripheral blood smear. Some maculations can be seen. This is the eosinophil, which we call the prettiest cell of the peripheral blood smear. The nucleus is usually, it is not multinucleated, it is bilobe. Okay, there is a fine connection here. So bilobe with large eosinophilic granules are there. Basophil is the size of almost that of lymphocytes. The granularity is they contain large basophilic granules. And neutrophil is nothing but here multilobated. 2 to 5 lobation is there and fine granular cytoplasm is there. Okay, so this is how the different cells will look like in the peripheral blood. One more term that I want you guys to know is shift to left. Many a times this word is used in the reporting. There is leukocytosis with shift to left. Now, if we see at the maturation graph of a leukocyte, this is a blast cell which arises from a stem cell and it undergoes gradual maturation as we move on the right side. So when I'm talking about shift to left, I mean to say that more of immature cells can be seen on peripheral blood. So this is the normal range. Some band cells and neutrophils can be seen in the normal peripheral blood smear. If I see some premature cells, I'll use those terms like promyeloblast, myeloblast. If I see those cells here, so that means that premature cells are there. And severe shift means I can see certain blast also. Okay, so these terms are important to know when we are using the term shift to left. That means the premature forms of those cells are seen on the peripheral blood. That means this patient needs to be investigated further. And platelets are, again, they are non-nucleated. They are actually cytoplasmic particles. They are not, in fact, a complete cell. And they are very small, a bit basophilic particles seen in the peripheral smear. And we have to know certain conditions like large platelet or giant platelets here. See, as we can see, you might think it is a lymphocyte. But if you look at it carefully, there is no cell membrane. This is not a nucleus. There is no nuclear membrane here. So what is this? This is a platelet. And This is if when we see MPV is increased, that is mean platelet volume is increased, this kind of cells are seen on peripheral smear. So this is important. And what are these? These are neutrophils, okay, and these are nothing but platelet aggregates. So platelet aggregate indicates the functionality of the platelet is good. What is the main function of the platelet? They aggregate and form clot. So platelet aggregate, if we see small aggregate, that means it's good. If we see very large aggregates on the peripheral smear, that means either the sample was not processed properly, the mixing of the ADTA was not done properly, or there is some etiological autoimmune condition involving in the platelet. So in such, if very large clots are seen, platelet aggregates are seen, we usually ask for a repeat sample. If in the repeat sample, which has been properly collected and processed, if we see again large clots, then the patient needs to be evaluated for any autoimmune condition related to the platelets. And the star of the peripheral blood smear is the hemoparasites. In Indian setting, the most important parasite is the Plasmodium. As you can see, it's a hemoparasite, that is, it is present in blood. RBC is the main target. And if we see such rings inside RBCs, then we say it is positive for Plasmodium. And depending on the structural details, we differentiate whether it's a Vivax or the Plasmodium. So two kinds of smears are prepared, thick smear and thin smear. The main purpose is that thick smear contain more number of RBCs. So we can detect the presence of parasite or absence of parasite. But we cannot, because the RBCs are stacked over each other very thickly. We cannot tell the subspecies of the parasite that is present. For that, we have to do a thin smear. Here, these are the thick smears. So on the left are the rings or the Scheissen's form, and on the right are the gamete form of Plasmodium vivax. And this is Plasmodium falciparum. If you can see, the rings are thicker, multiple rings in the single layer, and these are the banana-shaped gametes of Plasmodium falciparum. Another parasite which is very common in an Indian setting is filaria. So this is what a filarial worm looks like in the peripheral blood smear. And the ideal specimen for filarials, detecting filaria is the midnight specimen. You know, between 11 o'clock to 4 o'clock, because filarial worm tend to move out of their lymphatics high age point and go to the peripheral blood during that period. So if there is a high level of suspicion of filariasis, the nighttime blood sample is collected and immediately stained to check for filariasis. One more condition not very common in our setting here is Leishmania donovanensis. We can see the Leishmania bodies inside the WBCs. See, it's important to know where to look for. Leishmania will never see inside RBCs. They are seen inside WBCs. Okay, but malaria parasites are seen inside RBCs. And trypanosoma, this is a condition which is not present in our setting. It is more common in South Africa, which causes sleeping sickness. So these are also a type of heme parasites, and they are like filaria. They can be seen in the peripheral blood. And can anyone in the chat box tell me what kind of cell I'm pointing out here? What kind of cell is this that I'm pointing out here? It is not any kind of parasite. It is a type of RBC. So can anyone tell me what kind of cell this is that I'm pointing out here? If even one person tells me right, that means today's talk was successful. No, please think about it. Look at the color of the RBCs around it and the color of this RBC. No, we don't have any lymphocyte here to say whether it is microcytic or macrocytic. No, it is not hyperchromatic. See, we can see the central panel. It is a blue, it has a little bit of bluish tinge. So yes, some of you have written it. It is reticulocyte. That is polychromacy. Yes, thank you so much for that feedback. And so this was the last two slides is what is a sample report of CBC. So whenever now you read the CBC report, it will be read under RBC, WBC parameter and platelet parameters, hemoglobin, RBC count, packed cell volume, that is hematocrit, MCV, MCH, MCHC, RDW. Total in WBC parameters, total and differential count, and again look at not only this, which is the percentage. Look at these values, the absolute count. These are more important. I'm sorry. So these absolute values are more important. Look at these values. Okay. And the platelet parameters, again, total platelet count and the mean platelet volume. So these are the parameters that we will, and as I've already said, normal ranges are given in most of the reports. So you can, I hope from henceforth, when you see a CBC report, you will have a better idea of things. And this is what a typical PST report looks. Sparsely distributed RBC, that means what? That means the total number of RBC is reduced. And isopoikilocytosis means there is different variation in the size and shape of the RBC. But predominantly the RBCs are normocytic, normochromic. Then certain special cells can be seen, like target cells. Then there is mild leukocytosis with lymphocytosis. That means the total, the TLC is increased. And what is the cause of the TLC? There is increase in the lymphocyte count and there is increase in the eosinophil count. Platelets are adequate and no parasite is seen. What is the impression? Normocytic, normochromic anemia. And further testing can help us decide what is the cause. So that was it. Thank you.
Thank you
Yeah.
so much, ma'am, for the
Yeah.
very informative lecture. Thanks for enlightening us. I think someone had question.
Yeah, please.
Hello, good afternoon, ma'am. It was a really nice lecture indeed. Gave us a very good understanding, overall view. But a lot of things to remember at the same time. Would be good if you could get a recording. Will be really helpful to review it.
I've already shared the recording with Dr. Ankush, so you can take that from him.
Thank you so much. Ma'am, I have a question. So I wanted to understand, for example, in a patient who's having a long-standing autoimmune disorder, let's say RA, and in this patient, we generally see a hemoglobin is low.
Yes.
Because of the long-standing disease.
Yes.
Now, sometimes the patient could also have low hemoglobin because of iron deficiency anemia. So how
Yes.
do we rule it out? How do we read the iron ferritin report, I mean, as such?
Yes. See, we have to keep in mind three things. Number one, we have to evaluate the previous report of such patient. So unfortunately, in our scenario, in our cases, what happens, a patient do not bring previous report. If the patient is with us for a long time, we will have the previous report. We will look at the previous report and we get an idea, okay, this is how the report should be. But if we see certain parameters, like a patient of rheumatic heart disease, what kind of anemia should have? The patient should have an anemia of chronic disease, which should be normocytic, normochromic. Because the chronic disease, the chronic inflammation is causing a bone marrow suppression to a mild extent, which is causing a decrease in the total RBC count. Okay. But in such patient, if we see hypochromic cells, microcytic cells, that should raise a suspicion. Probably patient is having, on top of the chronic disease, additional nutritional deficiency. So it is not the PS which will diagnose. PS gives us a suspicion. And what will diagnose? We will now advise iron studies for the patient. So, or we can do special studies on the bone marrow, like iron stains. We can do a pulse reaction and iron stain on the bone marrow, or easier is get serum iron levels done. And then we can diagnose, oh, now apart from this, the patient is also having a nutritional anemia, right? So that is how we can evaluate.
Okay, but then again, in iron levels.
And one thing more is that this anemia due to chronic disease will not respond to the traditional conventional hematinic therapy. So that you can also evaluate clinically. And if it is a nutritional or that type of deficiency, it will respond. Means if it is overlapping, but it doesn't usually the picture. But in chronic diseases, they respond only on the treatment of the original root cause.
The root cause, right? And one more thing I would like to point out is that it's very important to evaluate iron status of the patient, because what happens is mostly what we tend to give is, okay, iron deficiency anemia hoga ya B12 hoga, and we start therapy. See, patient of anemia of chronic diseases many times have increased iron stools. On top of that, if we are giving them more iron, thinking the patient is having iron deficiency anemia can actually lead to iron overload in the patient.
Yes,
So
ma'am.
before giving any kind of therapy, if you have high level of suspicion, then better to undergo serum iron studies or to undergo a B12 and folic acid assay to evaluate what kind of deficiency the patient has, and only then treat such patients.
Sure. Yes, ma'am. And also, how is iron levels of low hemoglobin and a patient presenting with a viral fever or any fever per se has any correlation with iron, ma'am?
See, what happens is any kind of infection for that matter,
Mhm.
it gives a stress on the bone marrow, because the bone marrow is a primary source of all kind of inflammatory cells. So
Right.
any kind of infection or inflammation in the body induces the bone marrow to produce those inflammatory cells which are required to kill or get rid of those agents. And that kind of thing is happening at the cost of production of RBC. So the bone marrow is prioritizing. Acha, RBC ka production abhi hum thoda kam karte hain. Let's focus on, this. And in acute condition, that is not a problem. But if this thing persists for a long time, then the RBC production is actually compromised sufficient enough to produce anemia.
Okay, then the iron levels will be high, will remain high in the blood.
Yeah, why it will no? It will remain high in the sense what it will remain normal, because that is not the cause of anemia here, right? It is not the cause. And if for some reason there is some kind of blood loss is happening, some kind of, for example, malaria is there. Whenever the gametes rupture out of an RBC, RBC is ruptured. Hemolysis is hemolytic anemia is happening. So that releases excess amount of hemoglobin, which is absorbed by the bone marrow and kept in stool, right? So that kind of thing indirectly increases the iron stools in such patients.
Sure. Yes, ma'am. And then we have to rule out.
In some patients, in such patients, sometimes you may get a plastic type of picture also because of offending infections.
Yes. In the long term, patient lands into a plastic crisis as well because of this.
I have one more question, which is out of the CBC purview related to the LFTs. So suppose now commonly seen are hepatitis B and hepatitis C. Suppose we know a patient whose enzymes are high, and we know the ultrasound doesn't rule out any cause, no biliary pathology, nothing, and we still want to rule out hepatitis as a cause for the high enzymes. What are the tests you think we should do? Like HBV DNA should we go for, or go for a surface antigen?
Start with the basic screening test of surface antigen. Always
And it is normal.
Yes,
it is negative.
If it is negative and still there is high level of suspicion, if there is a high risk factor involved, the patient gives a history of high risk behavior, then we can go, because you know what, these tests have limitations. Very low titers cannot be detected in the screening test, so we can go for DNA level. But then again, we need to have concrete proof with us. Very high level suspicion, because these are costly tests. You don't want to spend all the money in investigation and nothing left for you. So we have to justify the test to be done. But if you think, the probability is very high, then those are the tests that can help us.
Then then there are those tests which has IgG, IgM, and surface, the core and encapsulated.
Those are again indirect evidences. Okay, those are evidences of our immune system responding to that. So we can do direct DNA analysis tests like PCR. Direct detecting the HPVs, HCV, and HBV DNA in the system. You can do those tests.
If that is not, if definitely there is some hepatitis existing infection, definitely HBV DNA will be high, no matter what.
It's similar to, like, I'll give an example of COVID, right? We are doing RT-PCR to check whether those viral DNA were present inside. So that is the basis of any kind of viral DNA testing, to check whether we have the DNA copies inside our body. So that is the best direct evidence possible, right? And IgG, IgM, those are indirect evidences, because those are evidences that our body is fighting against those specific molecules.
Basically, those are antibodies present because sometime there was an infection and it may disappear or appear, not really conclusive.
Yes, yes. As we all
Got it.
know that HCV, HBV are not curable diseases. They are controllable. For that matter, HIV also. They are controllable in
Right.
the sense that the viral DNA copies are kept to a minimal detectable level.
Sure, sure. Thank you so much, ma'am. That was really helpful.
Yeah, sure.
Sometimes biopsy can be done for assessing macronodular or micronodular type and whether it is post viral or alcoholic type, that you can also guess for.
Yeah. Sure, sure. Again, biopsy is a thing that we would consider the very least thing because, it is has its own complications and pros and cons. So blood test would be
Yes,
the
that's
first
right.
level.
But
We
you
also
are
try
not.
to first evaluate the patient by non-invasive techniques, and only when absolutely required, we go for invasive techniques.
Yeah, I agree. Biopsy is the gold standard. That is true to be like absolutely conclusive. Yeah, I understand. Thank you.
Yeah. Any other questions? I see a question in the chat box to give an example of an inflammatory disease, CBC. I will try to look it up. I don't have any such reports with me right now, but I'll try to look it up and share it with Dr. Ankush, and he can share it with you.
Yeah, ma'am. Sure.
Yeah.
Yeah, I thought it was a very nice discussion between our speakers and the participants. Now I would like to request our president, respected Dr. Subhash Wage, sir, for the chairperson's remark. Over to you, sir.
Thank you very much, Ankush. I must say, indeed, it was a very excellent lecture from Hadgaonkar madam. Very confident, very informative. And after going through the CBC analysis, we are tempted to go for PS study. Obviously, for reasons, as soon as you come to know across the anemia, you would like to know what type of anemia it is, whether it is microcytic, whether it is macrocytic. That you will be able to evaluate on PS. Similarly, in TLC also, if you get very high number of neutrophilia, you suspect severe sepsis, septicemic-like condition, then you would like to go for whether there are toxic granulations in those things, or there are band cells in the PS. So the PS helps the CBC picture supported with the PS findings makes the perfect blend of diagnosis, I suppose. And particularly when in our Indian setup, many times physicians suggest us that please look for the parasites carefully, because this you need to be very cautious regarding the falciparum malaria that can land into the encephalopathy. But most of the time, sometimes it happens that patient take some dose of chloroquine by themselves or over the counter, and then then you withdraw the sample, and then you may not be able to find the ring forms on the typical classical ring forms on the
Yes.
PS. That is very means dilemma like conditions. But you need to have a very strong suspicion. Then these are some conditions. And one more thing that has been mentioned by though trypanosomiasis is not common in our country, but some 3-4 years back the case was reported from Chandrapur only.
Yes,
So,
yes, sir.
yeah. So that is also we can come across all these rare things also in PS. That's so all in all, it was a very wonderful, very informative lecture, madam. And I thank you on behalf of entire RBPG team. And I'm quite hopeful that in future also, whenever we call you and we would like to have the to that from your to share the immense knowledge from your treasure of knowledge for our PGs. And I suppose and I hope that our PGs are much more wiser than before with this lecture. And this is, and I can see that also. When used to I typed to get give the answer, the students they themselves that they have answered the polychromacy and etc. And so it was that shows that this lecture was very fruitful. So thank you very much, madam, once again. Thank you. Over to you. Ankush?
Thank you, sir.
So thank you for the kind words and thank you for highlighting the very important part that I missed. That whenever we are taking samples for parasitic infestation, we have to first collect sample and give them the dose of medication because even a single dose of medication can alter the morphology and can, the pathologist looking can miss out the diagnosis. So thank you so much for pointing out a very important part and thank you, sir, for your kindness. Yes,
Thanks,
Ankush.
ma'am.
Dr. Ankush.
And our this webinar is accredited from Maharashtra Council of Indian Medicine, and it is having the credit points also.
Oh, wow. Good to know.
Thank you, sir. As you all know, the last step of every event is a vote of thanks. And for that, I would like to invite Dr. Pallavi Chaugule, ma'am. Dr. Pallavi Chaugule, ma'am.
Yes. Hello. Good afternoon, all. Hello. Am I audible, sir?
Yes, ma'am, you're audible.
Yes. Myself, Dr. Pallavi Chagule, working as Joint Secretary of RVPG. I would like to thank Dr. Kajal Hadgaonkar, madam, for such an elaborative, well-structured, informative session, and in such a simplified way. Definitely, our all audience must have been benefited with it. I thank you wholeheartedly, ma'am, for sparing time with us on this platform. And I'm looking forward for further collaboration in future also. Sir. I also thank all the audience for their enthusiastic and active participation. I would also like to thank the organizing committee of RVPG for organizing such an informative session. Thank you one and all RVPG organizing team. Thank you. Over to you, sir. Ankush, sir.
Thank you, ma'am. Thank you, everyone. Once again, thanks to our guest speaker for the very informative lecture. Thanks to the energetic participants. Now, with the permission of our president, can leave this meeting.
Yes.
Yeah, thank you, sir.
Thank you again for allowing me to speak. Thank you so much.
Yeah,
Thank
thank you, ma'am.